Okay. Good evening, everybody. Uh, Today's topic will be in our GI series. It's dyspepsia, and dyspepsia is a common complaint, which which is given at at the exam, long cases, because this is one of the common initial complaints of patients. Uh, Discomfort, pain, and all these symptoms are put together. It is called dyspepsia, and the long case will be on this. And also, this covers a number of upper GI disorders, so that it can be tested under MCQs and SCQs as well. So, episodic epigastric pain and discomfort. Let us move on. Okay. Moment the question comes or the patient is encountered, this is the general presentation. Either a young or old man will be given. 35 and 65 I have put it as the age. Depending on the age, because the differential diagnosis can vary a little bit. So epigastric pain and discomfort, collectively called dyspepsia. And immediately what you have to do is to remember the working diagnosis or the differential diagnosis. Otherwise, your history taking and the way you are going to tackle the question will not have any guidelines. So, basic things you have to think of is basically the key organ there in the epigastric and upper abdomen is the stomach, and the left liver lobe is also there, as you know, and the pancreas. So basically you have to think of the gastric problems and pancreatic problems plus lower gastroesophageal problems. And sometimes the duodenal and upper small intestinal problems also might present as upper gastric area problems. So I'd rather make you to think that it's better if you have this working diagnosis, that is peptic ulcer disease and gastritis, especially in a younger patient, and chronic pancreatitis. Remember, this is going to be a cold case, so acute pancreatitis doesn't fall into this category. Maybe there is a history of acute pancreatitis, but basically you have to think of chronic pancreatitis and pancreatic cancer. Third diagnosis will be gastric cancer. This is one of the sinister causes, and we always, when there is a GI complaint, think of that. The gallstone disease, generally this is come under like hypochondrial pain, but then again, the upper part of the abdomen, any pain, think of gallstone disease, and then gastroesophageal reflux disease. There are many other, you must remember, you would have been taught many other differential diagnoses, but this is called the working diagnosis. So your discussion, if it is based on these 5 common problems, then even if you miss out some rare causes, like let us say aortic aneurysm or some rare lymphomas, retroperitoneal diseases, which are also possible, you will not lose much marks at the MBBS level. So when you're taking the history, basically in the long case, if your case is a dyspepsia or upper gastrointestinal complaint or upper abdominal pain, any of these will follow the same pattern. So there are 10 points given in this marking scheme, which are common points given to the examiner also to see whether the candidate has thought of these things. So description of the pain is important, and you can do it under the Socrates, well-known thing, because the site, onset, character, radiation, association. I'm not going to go into details, but each area, if you have elicited in your history that you have looked for a site and you have mentioned about the onset, all these things will point towards one of the diagnoses. So that when you say the pain was felt in the epigastric or retrosternal region, I know that you are thinking of reflux disease or some sort of a gastric inflammation. And then onset, again, acute or chronic or episodic, you have to mention. The character is either a vague pain or a stabbing pain in pancreatitis. The radiation to the back is again important. Associations, vomiting, appetite are again important. So when you have to describe the nature of the pain first of all. So halfway through, when you are presenting the case, when you are giving these features, in any case, the first part of the history is to describe the presenting complaint. Halfway through, if the examiner stops you and asks, why did you ask for this? What is the importance of this? What is the interpretation of this? Then you should know that. And the second point, generally expected, second, third, and fourth points I have mentioned here, the relationship to the food intake. All epigastric problems, relationship to the food intake has to be there in the history. And weight gain and weight loss, because as you know, as we will soon learn, like in duodenal ulcers, people do eat a lot and then they become fatter. And on the other hand, if it's a gastric malignancy or a gastric carcinoma, there may be loss of weight. So that feature should be in your history. The fourth point will be periodicity. Again, peptic ulcers between duodenal and gastric ulcer, the periodicity is there, whether it has been there for a long time, whether there are periods of exacerbation and remission. In fact, if you have taken it under the nature of the pain, so be it. But somewhere it has to be mentioned. The vomiting and regurgitation, again, you might have taken that part under the nature of the pain. But that is an important part we are looking for you to mention. So depending on the presenting complaint, you will realize that there are certain key points we are waiting for you to say. And the sixth one will be a delayed abdominal pain, colicky pain, central abdomen. We are thinking of mesenteric angina. That's an important thing because many people miss to mention that. And then radiating to the back, chronic pancreatitis. Again, in the first part, you might have taken this, but this is an important part. And loss of appetite and loss of appetite specifically is important. Because when it comes to stomach cancer, that is a sign of presence of stomach cancer or gastric cancer, or it is a feature of hepatic metastasis. And then the nature of the stools, steatorrhea in chronic pancreatitis. So like this, all these features, we see whether you are mentioning in your history these important features when there is a case of epigastric pain. Okay? And generally what we do is, if you have mentioned more than 7 or 8 points out of these, in that section you pass. So you have to practice close to the exam. There are 12 or 13 long cases, possible long cases, all have this type of leading questions, about 10 leading questions, which I'm intending to uh, give in forthcoming lectures. Uh, be prepared to include these things in your history, depending on the presenting complaint. Then the second examiner will be naturally asking, the first examiner, the second part actually, will be asking about the examination findings. So, and there will be a short discussion in between about the interpretation of the history. So, whatever the points we have told, if you have not told, then what I will do is I'll ask whether you have not asked about loss of weight, what is the significance of it? Those are called salvaging questions, because you have missed to ask, we have forgotten to ask that. But to see whether, if you have asked it, whether you know the importance, we can ask questions like that. And once that short interpretation section is over, we'll be moving into examination findings. So, abdominal examination you have to practice, and then generally what happens is epigastric pain, always epigastric pain or dyspepsia, always look for a mass very carefully with superficial palpation and deep palpation, because most of the time you either if there is a patient with a palpable gastric malignancy or even a palpable left lymph node metastasis, it's a possibility that he will be given for the exam. So always look for a mass there. And then if it's a vague mass and the patient is complaining of vomiting and regurgitation and vomiting, elicit the sign of suction splash. So if the suction splash is not there, just move it and keep your stethoscope on the epigastrium and move the patient and see. Even if you don't hear, it's a rare sign, but you say that you try to elicit it, but it is not there. Okay. And abdominal examination, under general examination, the few points you get here, general examination, anemia, sorry about this order, jaundice, emaciation, supracalculus lymph nodes, and signs of alcoholic liver disease. Just look for, I mean, if there's palpable mass there, and then you think that he's especially a chronic alcoholic. So these features you should be able to interpret. And if halfway through, when you are saying that he doesn't have jaundice, he is not anemic, or he's pale, what I will do is, that as an examiner, what the examiner might do is that he will ask for an interpretation. If he is emaciated, what are you expecting in his presenting complaints? What is the differential diagnosis? So look for these things in the general examination part. And again, moving on to examination, always look for palpable epigastric masses very carefully. And sometimes the patient might say that there is a mass, people felt. So ask him. And any other apoquadrantic masses, like even left lobe metastasis and enlargement, will come as epigastric mass. And palpable liver, you have to specifically look for. And free fluid, look for it. Sometimes these features might not be there, but we expect you to say as relevant negative findings. There are again 10, I have bracketed under 10 features. So these 10 features we'll be looking for. So at the end, it's always better if you say that the chest examination didn't reveal any signs of consolidation or effusion. But don't spend too much of time in the exam, surgical exam, listening very too carefully for heart murmurs and lung signs and things like that. But make sure that you just put your stethoscope, and if there's an obvious heart murmur or something like that, or if there are chest signs, we expect you to find it. And always say at the end of examination, to complete my examination, I would like to do DRE. If you have not done one, DRE and a VE, vaginal examination. I might ask, the pain is in the epigastrium, why do you want to do a DRE? So just say that uh, pain may be related, it's coming from the epigastrium, but I would like to examine to see whether there are any pelvic deposits which can come from gastric malignancy. As you know, Blummer shelf is a pelvic deposits of gastric malignancies. And also say that I have examined the genitalia. If I have not examined, say that I would like to examine genitalia, especially in a younger patient, because testicular cancers can have large lymph node masses, retroperitoneal masses, parietic masses, which can present like either backache or sometimes epigastric discomfort and epigastric mass. So you just mention those things uh, for to complete the examination. So these are the main 10 points I would expect to be in your examination finding. Blummer shelf, the sign, are you referring to somebody has asked what was the sign? Didn't hear. It's Blummer shelf. Okay. Blummer shelf is a mass, bimanually palpable pelvic mass due to secondary deposits, pelvic peritoneal secondary deposits from upper GI malignancies. Let us move on to a quick MCQ. Regarding investigation of epigastric pain. True or false? Flexible endoscopy is the primary investigation of choice. And this knowledge will be tested in a long case by the second examiner because he will be moving into investigations. So this knowledge will be tested there in that way, or an MCQ like this. Anybody would like to attempt? Flexible endoscopy is the primary investigation of choice. False, false, yeah. Okay. Well, let us check the answer. Yes, this is true. Because all epigastric pains, uh, primary investigation of choice. I'm not quite sure whether you are thinking that we should mention the basic investigations and then UFR, Durias, X-rays in that order. True. I mean, if you are a house officer, you will keep on ordering these things in that order. Non-invasive techniques, then move on to more invasive techniques. But when it comes to investigation of choice, is the investigation you are going to do to find or throw some light into the exact diagnosis. So when it comes to upper gastric pain, discomfort, uh, in your practice also you would have noticed that flexible endoscopy, or what we call upper GI endoscopy, is the first choice. So the word is primary investigation of choice, not the first investigation you will order. It's a different one. Endoscopic ultrasound is not useful in tumor staging of stomach. Any guesses? Yeah, endoscopic ultrasound, when it comes to staging, yeah, it is false. No, it is false because it says it's not useful. It is useful because though the staging is basically done with CT, contrast-linear CT, when it comes to the luminal extension, uh, endoscopic ultrasound is playing a major role nowadays. So most of you all have got it right. It is false. But remember, this MCQ might be twisted the other way around. If it might say it's the first investigation or primary investigation in staging of stomach, which will be again false. Okay, so it may not be. It is not the primary first line of investigation. So just knowledge on that can be tested this way. MRI is better than CT in staging a gastric cancer. Anybody like to attempt? Yeah, because of the time constraints, I think we'll move on. It is false because when you take MRI and CT, the advantage is MRI is better for soft tissue delineation, but when it comes to gastric cancers and upper GI cancers, there's no difference. So contrast enhanced. CT is, if you say MRI is better, it is not true. There's no added advantage. PET-CT will avoid radical resection in 10% of cases. So if you are planning to do a radical resection or tier 2, tier 3, there are various ways of resecting the stomach for stomach cancer we are talking about, right? Uh, Gastric cancer again. I think that word is missing here. It should be radical resection for gastric cancer. It will change your management in 10% of cases. Anybody says true? Somebody is attempting? Yeah. Okay, there's a mixed answer here. Answer is it true? Because if you do a PET-CT, whether we should do a PET-CT to avoid this 10% is a different question. But it has been shown very clearly if you do a PET-CT, the difference is, as you all already know, is that PET-CT is a functional and structural investigation, while the CT is just a functional structural investigation. So the PET-CT will show hotspots when there is a active going on. So if you find active metastases outside the confines of the stomach or the node area, then you will not do any radical resections. So there are 10% of cases where you will not find these metastases by routine investigations. So by doing a PET-CT, you will avoid in that group of people, you will avoid doing radical resections. Laparoscopy is helpful in detecting posterior extension. Laparoscopy, this is maybe a little too much for you, but this is a question which has been there. Again, a mixed answer. The answer is false because I would have mentioned last time when we were discussing dysphagia that laparoscopy is basically important to detect peritoneal omental deposits. But when it comes to the stomach, uh, posterior extension is basically seen in imaging rather than endoscopy. It's not a good method of finding posterior extension. Because as a diagnostic measure, I'm telling about a diagnostic measure. Just a summary of investigations you will do when it comes to long case discussion. Dyspepsia or epigastric pain. These are the investigations you have to go in this order. Most non-invasive, full blood count, and renal function tests, UFRs. For any long case, whom you will think will end up in surgery, you can mention this part. So this is a very routine part. Up to the chest X-ray, ECG, renal function test, you just mention. And it is, if somebody asks why are you ordering these things, you say it's pre-op assessment. And plain X-ray abdomen, generally, if you mention, invariably they will ask, why do you want a plain X-ray? So interpretation you have to be uh, aware of. That is pancreatic calcification you might in chronic pancreatitis and nephrocalcinosis and in hypercalcemia and chronic pancreatitis again. If you see a lot of nephrocalcinosis, you have to think of hypercalcemic status, which can have will be associated with could be associated with chronic pancreatitis. But basically, if you mention chronic pancreatic calcification and calculi, suffice. Ultrasound abdomen is important. Again, diagnosing chronic pancreatitis, and pseudocysts are actually a sequel to acute pancreatitis. So you must say that ultrasound can be done to detect hepatic metastases, free fluid in the abdomen. But when it comes to the pancreas, it is not a very reliable investigation because it is covered with intestinal gas and gastric gas. So pancreas, ultrasound of the abdomen, pancreas is not a good organ to view. Uh, then when it comes to CT, next one is the CT, and that is the most important contrast in a CT. It is best for pancreatic lesions and also cancer stage. Here we go. Let us move. Then the investigation of choice is upper GI endoscopy or GD, and you have to, I must mention that you have to know everything about this because in many stages of your exam, this common investigation, the knowledge of this common investigation will be checked. So it's best to diagnose peptic ulcers, reflux disease, and malignancy. And ERCP, you have to mention that it is an extension of upper GI endoscopy.
GID, peptic ulcer, malignancy, reflux, gastric malignancy.
Yes. And endoscopy and ERCP, you can mention with the upper GI for more details. So if you say that you will do upper GI endoscopy, you say that if I'm suspecting pancreatic, because especially if it is a diagnosis of chronic pancreatitis, you say that upper GI endoscopy with a view to go ahead with ERCP. And MRCP, MRI doesn't have an added advantage, but in some soft tissue lesions, MRCP, and also especially if somebody is allergic to iodine contrast. Always, if you are asked, magnetic resonance investigations are better than CT, most occasions you will escape by saying it is not. But if the CT involves iodine contrast and somebody is allergic to it, MRCP will be, or magnetic resonance will be useful because it gives equal results. But it's more, in a way, more expensive and more cumbersome to do. Move on to another MCQ. What is not true regarding gastritis? This is best answer type of question. Only one answer will be right. Can anybody go through this quickly and say what is the not true answer? Type A is, now regarding gastritis, you know there are two types. We have been taught already probably. Type A and B. Uh, type A is an autoimmune disease. It says type A is an autoimmune disease associated with hypoacroalhydria. Type B with H. pylori. Type B most often affects the body and fundus of the stomach. And both A and B are precancerous. Yeah, some people have tried it. The fourth answer is the not true answer. You are right. Because type B is generally, it is diffuse. But otherwise, just learn about type A and B, the difference. But how you will remember is that type A is autoimmune, A for autoimmune, B for bacteria, okay? B for bacteria, H. pylori. So no time to go into details, but these two differences you have to know. And because the treatment may be different. Okay, because type B is not confined to fundus or stomach, it is pangastritis that involves the whole stomach. Uh, they are both A and B are precancerous. A due to pernicious anemia, because it will lead to pernicious anemia because of the intrinsic factor deficiency. You all have been taught from physiology days. And type B is undergoes intestinal dysplasia. So both are precancerous due to two different reasons. That also you must know. One is due to pernicious anemia, which is precancerous. Other one is due to intestinal. It is B, it is due to intestinal dysplasia. Another common question we ask by the second examiner, because depending on the way you have answered at vivas and long case even, these are few questions which we expect at a house officer level, but for you to know. So, how do you prepare a patient for upper GI endoscopy? So, you have to be ready with this standard answer for any patient. Explain the procedure and benefits and potential complications. How do you explain if the examiner asks or somebody asks? You say you will give the benefits first, always, like taking the consent. That is the next natural extension, is getting the consent. You explain the procedure with benefits, and then you have to mention the common complications. The very rare complications, even if you know, like death and near-death complications, um, in many occasions we will not mention them, though you must say that at the end of explaining them the common complications, there can be other unexpected problems, for all of which we are ready, we are prepared to face. But if you keep on mentioning about death, that there is 0.1% chance of dying, which is there, I think that is not going to go in a good way. So when you're taking the consent, common complications, followed by, you must say that there can be other complications. Uh, then getting the consent and fasting for solids for 6 hours, clear liquids for 2 hours. There are various regimes, slight modifications of regimes, but stick to one. If you have been taught one way of doing it, stick to that. Is a standard answer we are giving. Prolonged fasting may be needed in certain situations, like if you suspect gastric outlet obstruction. Somebody is complaining that he is vomiting frequently and you are suspecting a pyloric stenosis or some sort of a outlet obstruction, then you might not get a clear picture if you don't make him to fast a little longer. And withhold antiplatelets and anticoagulants in advance. This is sometimes a kind of controversial thing, but easy way to escape is that just say that withhold antiplatelets and anticoagulants only if you are intending to take a biopsy. Because if you suddenly see a mass there and your clinical suspicion is strong and you are planning to see a mass there, definitely you will be taking some biopsies, and you don't want to take a biopsy in a patient who is on warfarin or has a very high bleeding tendency. So say that if you are expecting to take a biopsy, you will do that. So that will show that you are thinking safe. And these 10 points, like catheterization, these 10 points, I'm not asking you to cram it and then try to memorize it. But if you try to remember this is very commonly asked uh, question again. Uh, what are the steps of performing an OGD and ERC, both more or less same? And at the second part of the long case, or especially at vivas. And also we can make a couple of MCQs from this too. So learn these points, uh, identifying the and confirming the patient, uh, procedure, and always talk to the patient and explain him and request to cooperate, because otherwise, unless you have given a picture about what you are going to do, it's going to be very difficult. I'm sure you would have had a good practical experience during your training, but when it comes to the exam, however good you are, you might have done even OGDs, okay? But still, I think if you don't give these points, express these points, you'll be judging by what you see. And consent has to be taken, and then 10% nicotine spray. Always the percentage, remember, and to the oropharynx with a canister and a stiller. There's a to spray it. Somebody might ask a quick question: how do you spray the pharynx? Just to see whether you have watched one procedure. And midazolam uh, and buscopan to reduce the gastric mortality. And midazolam, especially if it is given IV, patient tend to forget the procedure when he comes out of it. So it's good for him. And position the patient in left lateral position, and mouth guard. Don't forget to say that mouth guard, because these are expensive instruments. If he bites, millions of rupees can go waste. And side weaving endoscope lubricated with lignocaine jelly. Identification of growth distance, and you measure the distance to the growth with measuring it like putting an NG tube from the incisors to earlobe and then down. So generally, what is, you can't do that with the endoscope inside your mouth. NG tube you can, NG tube, nasogastric tube, you can measure it from incisor to the earlobe and up to the stomach, epigastrium. But here, you distance, when you want to record, you measure it from the incisors. And cannulation of pancreatic duct and injecting contrast is part of ERCP, as you know. And last advice you have to give after recovering, after finishing the procedure, is to uh, try not to swallow till the anesthesia is over, because they can aspirate. So I'm sure this would have been given to you several times, but remember, these are the 10 points we expect you to mention. Then again, the pre-op preparation, a commonly asked question when you are involved in any epigastric problem, surgical problem. Pre-op preparation, most of you all must be by now, you are ready to answer this question for any major. It's like any other major procedure, like a laparotomy or any other major procedure. So consent, checklist, and don't forget to mention the WHO checklist. Nowadays, it is very popular. So you say the checklist to check these things, plus fill the WHO checklist. At least the word WHO checklist should be there when you are answering a question, or when you are uh, answering a question on paper, or when you are answering question at a discussion. So checklist, that is because it is a house officer's job. So we expect you to know that. And all special investigations to be sent, like CTs, MRIs, endoscopic findings, to the patient, with the patient to the theatre. This is actually a general discussion. And nutritional and serum protein correction has to be done for any kind of surgery. And this is upper GI surgery, remember, it's going to be very major surgery. Whether it is going to be a pancreatectomy or a gastrectomy, doesn't matter. So nutritional part, many times you forget. So when you're writing an answer also, if it is a SEQ, this can come as a SEQ as well, one segment of SEQ. These are the points we'll be looking for. So say that protein correction is important and nutritional correction is important. And because it's an SEQ, it's an answer, essay type of answer, you have to write it in short sentences, at least 3-word sentences. And correct coagulopathies, PT and INR, and inform the hematologist if there are complicated problems like heart valves and people are on warfarin, heart valves with anticoagulants, the newer anticoagulants, and then where you can't stop the anticoagulant. So the bridging therapy, you would have heard about it. This is not the time to go into details, but read about it. You will say that you inform the hematologist in case of there is complicated coagulopathies, acquired coagulopathies, like coagulation done for heart valves and like von Willebrand disease or hemophilias. Inform the hematologist. So he will give a regime before going for surgery. And good hydration before coming for surgery is important. And then antibiotic prophylaxis. Bowel surgery is generally taken as clean contaminant type, so prophylaxis is a must. So these 6 or 7 points you have to remember. Move on to another MCQ. Consenting a patient for OGD. What is not true about the risk uh, information? That is in a consent form when you are taking the consent. What is not true? Sedation could cause, this is regarding OGD, remember. Sedation could cause respiratory arrest. Sedation. Any guesses? Okay. Yeah. Answer will be, yeah, I one answer there. So this will come as a best of 5 answer. Just know these are the complications of OGD. So if you know the complications of OGD, sedation can cause respiratory arrest. So we have to be aware of that. Tongue and teeth damage is again a common problem, not a very common problem. But in post-procedure hematemesis, especially if you have taken a biopsy, there's a possibility of that. And bradycardia and cardiac arrest, again, it could be due to sedation or vagal stimulation, especially when you are moving inside the stomach. There is a possibility. Why this is the last answer, which is the wrong answer, actually. Uh, Chance of perforation 1 in 200. I'm sure that my GI colleagues will be very unhappy to maintain a figure like this. It is in experienced hands, this is 1 in 1500. So when you're talking to the patient, if patient asks what are the chances that this will get perforated, and because perforation is the most dreaded complication, if you have this figure at hand, I think it will be useful. Some very experienced people say it is 1 in 3000 procedures. 1 in 200 is far too high. So that's the only wrong answer. Another little MCQ regarding treatment of peptic ulcers. For duodenal ulcer, first line treatment is triple therapy with omeprazole, amoxicillin and clarithromycin, OAC. How we remember that is amoeba, ova and cyst. You know what we look for, look in a stool sample. Amoeba, ova and cysts, OAC. So it's same as this triple therapy. You are keeping on forgetting it. Omeprazole and amoxicillin and clarithromycin for 10 days. So there can be trick parts in this MCQ where the number of days and type of medication. So it has to be a proton pump inhibitor, broad spectrum antibiotic, and clarithromycin. So anybody? All true, 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 false? First one. I am sure that I am getting the response for this. A mixed answer actually. It's true. This is the standard treatment, triple therapy for uncomplicated peptic ulcer disease to start with. And in depending on the country and the experience of the person, these regimes can change. Now, various guidelines might give different regimes, but for your practice, if you mention this, always it will be safe. Best way to diagnose Helicobacter pylori infection is endoscopy and biopsy. Second question, any guesses and attempts? False, false, true, false, true. So yeah, again a mixed answer. So answer is false because there are many other non-invasive techniques, because sometimes back, that was the only test we had. But now there are non-invasive techniques. You should know that serological methods, urea breath, no time to go into all details. But I think if you know this fact, I think you can read around. And urea breath test and urine or blood detection of H. pylori antigen even in uh, uh, stool samples. So details you would have been taught already in lectures. So just revise those. But endoscopy and biopsy is not the best way, single best way. But there are, because it is an invasive technique, number one. So if there are non-invasive techniques, you always mention that first. And this can be converted into other MCQs. All these techniques can be broken into MCQs again. In Helicobacter pylori infection, bismuth-based therapy or levofloxacin-containing triple therapy are alternatives to first-line therapy. First-line therapy, as you said, as we already mentioned, it is the first answer, first-line therapy. So, any attempts? Any would like to try? False, 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 true. Okay, it is false because it is actually a second line therapy. It's not an alternative to first line therapy. If you say alternative to first line therapy, then somebody might decide not to give first line therapy with OAC, but to replace it with bismuth based or levofloxacin containing. Those are all second line therapies, you should remember. So it's not an alternative, it is second line therapy. Surgery is indicated after triple therapy failure. Surgery. If the triple therapy is given and if it fails for peptic ulcer disease, if it keep on recurring, surgery is indicated after triple therapy failure. Any guesses? Yeah, somebody has tell, isn't the gold standard is, yeah, gold standard is, we are right. But the gold standard is if there are any simpler methods are negative. And then the clinical features are very suggestive of still HPAC, that problem, some kind of problem, maybe H. pylori or in other conditions. If the cause is not very clear, then you say that the gold standard is this. But if the other tests are there, non-invasive tests, which can diagnose it commonly, more frequently, then of course, uh, best way to diagnose is you should not mark it right. And surgery is indicated after triple therapy failure. Anybody trying? Yeah, true, true, false, false, false. Again, mixed attempt. Uh, yeah, it is false because answer is already we have given, because first line therapy OAC fails, you keep on attempting second line therapy with various other combinations. For you can read about it, time permits. Uh, it's not the surgery. Surgery is the last measure you will go for nowadays, because peptic ulcer disease is one disease, as you know, has become a medical disease taken out of surgeons' hands, like BPH, benign prostatic hyperplasia. Two great surgical diseases which got converted into medical diseases is one peptic ulcer disease, other one is the benign prostatic hyperplasia. So surgery, yeah, these are just few things. I think you will get this. This is just an outline of treatment. You can go through this slide leisurely. Surgical treatment is rarely done, you must say that. But if your discussion continues in the long case, last part they will ask, what are the surgical, because it's a surgery exam after all, can ask what are the available surgical treatment. You have to just know the outline. Like good old days, you don't have to know all the details of the surgery, because surgery is not the first line treatment anymore. And it is actually reserved for refractory cases, and it will be by removing the acid producing or diseased organ, that is the stomach, to reduce the acidity especially. So various types of gastrectomies are there, but they are hardly ever done nowadays. Billroth 1, Billroth 2. If somebody mentions, one of the senior surgeons mentioned, have you heard about this? You must say that, yes. There are 2 or 3 types of gastrectomies you can do for peptic ulcer disease. And Billroth 1 is just remove the distal part of the stomach and bring the duodenum into the stomach. Billroth 2 is you remove the distal part of the stomach, but the jejunum, there's a gastrojejunostomy here. And you always must remember that there's a danger in this Billroth 2, because gastric juice here is straight away coming to the small intestine, which is not quite familiar environment for the gastric acid, and you can get ulcers there later on. The idea is to reduce the ulcer producing area. And total gastrectomy is also recommended if it's a gastrinoma or Solling-Ellison syndrome, because whatever you do, the stomach will keep on making ulcers. Side effects, you have to know a few things to answer your MCQs. Dumping syndrome and vitamin B12 deficiency, because both needs the stomach. Dumping syndrome, I'm sure you have some basic idea, where this function of storage of the stomach is gone, then suddenly the food bolus, without being released periodically, it just gets emptied into the intestine. So, and there are series of acid reducing surgeries called vagotomies, which again you have heard, and it could be truncal, selective, superselective. I'm not going into details, because very unlikely at your level it will be asked, but in MCQs, you should have this basic knowledge. Out of these vagotomies, what is practiced, if at all, is the superselective vagotomy, where the distal part of the vagus is left untouched, because that is the part which will supply the pylorus. So this dumping and pyloric stenosis, the pyloric obstruction, because if you cut that nerve, pylorus will not harmonize with the stomach. So that is a problem. So that will be prevented if you leave that distal part of the nerve, which is called nerve of Latarjet. This is your anatomy knowledge. So superselective vagotomy is the only vagotomy we do, and all these surgeries are nowadays are done laparoscopically. So rather than as open surgery. We are coming to an end with the time now. So we'll do a couple of MCQs and then move on to other causes of epigastric pain and dyspepsia. Regarding risk factors of gastric ulcer, increased risk with diet low in sorry for these spellings, salt, low in salt, increased risk. True, false? True, false, 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 yes. All, yeah, okay. Many people have, occasionally it's a true, yeah. It's false, because high salt and smoked foods Uh, Generally, smoked food also carries high salt, but high salt is the risk factor for gastric cancer. Fruits and vegetables, vegetable intake is protective. True, false? True. Yeah, it's true because it has been shown in some studies that fruits and vegetable high intake is protective for gastric cancer. Family history of stomach cancer? Yeah, most of you all have got it right. It's true. There's a familial tendency for stomach cancers. And then infection with Helicobacter pylori, that's again true because not only the peptic ulcers, gastric cancer also has a connection. Chronic iron deficiency anemia, iron deficiency anemia. That's the part which might put a question mark in. True, true, false, false. Yeah, mixed answer. False, because iron deficiency anemia itself is not directly connected with stomach cancers. So basically, it's B12. Uh, yeah, but there is pernicious anemia. Iron deficiency is different, and smoking and gastric polyps are the other risk factors. I think we will move on. I think this is a large topic, so we won't be able to finish in one day, maybe a day more. So we'll move on with the other common diagnoses and the treatment of them next time. So for the time being, uh, thank you and good night.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.